Good afternoon and welcome, ladies and gentlemen. This is a special called meeting of the House Insurance Subcommittee. It's Monday, September 26th, the year 2022. It is just a few minutes after noon. Ms. Adams, if you could please call the roll.
Representatives Hickey? Here. Hicks? Here. Kumar? Here. Lafferty? Here. Mitchell? Here. Rudder? Here. Terry? Thompson? Here. Chairman Hawk?
I'm here.
You have a quorum.
Thank you very much. We do recognize a quorum. We most likely will not take any votes, but the potential to call a vote could come up, and if so, we do have a quorum and we'll continue to recognize a quorum throughout the meeting. The purpose of today's meeting is to have some discussions about TennCare, both give us an idea where we are with TennCare 3, where we are in terms of negotiations and back and forth with CMS on our conversations there. Also, we want to talk about the any issues we have with waivers, just to get an update of where we may be in terms of waivers and potentially discussion of contracts. There will be some issues that have become news of the day that may come up as this meeting arises as well. I do want to take a personal privilege before we get started. We have a new research analyst for the committee. To my left, Harris King is our new research analyst for Insurance Full Committee and Insurance Subcommittee. Let's welcome Harris.
Thank you.
And additionally, one of our favorite people in the room is having a birthday today. Tyler Munoz. We're not going to... I paused for a few moments there because I was going to ask you how old you were because your mom can't remember. So she kind of forgot. But happy 34th birthday to Tyler. So congratulations to you. He is of legal age. So if we could, we will begin our meeting today, and we'll ask Director Stephen Smith of TennCare to come find a comfortable place at the tables. And Director Smith, if you could introduce the folks that you have brought with you today. And I believe we've got a slide presentation. We've got some hard copies of the slide presentation as we get going, but we do have the slide presentation. And Director Smith, you are recognized.
Thank you very much, Mr. Chairman and members. It's good to be with you all this afternoon. My name is Stephen Smith. I serve as the TennCare Director. To my left is Drew Staniewski. He is our Deputy Director. And then to my right, we have Dr. Victor Wu. He is our Chief Medical Officer. To his right is Aaron Butler. He is our Director of Policy. And then to his right is Zane Seals, and he is our Chief Financial Officer. As you said, Mr. Chairman, we've been asked to provide a number of updates, and in the interest of time, we will jump right in. And I'll start with the TennCare 3 waiver, which is a waiver that you all, this committee, is very familiar with. This waiver has actually been in place for almost 2 years now. It's kind of hard to believe. And we've had great success, and we are very optimistic about where we are headed in the future, and I'll talk a little bit more about that. But there has been some recent movement at the federal level around this waiver, and so the timing of this committee is really good. So just as a refresher, a little historical context, per legislation that was adopted in 2019, we submitted a waiver amendment or a waiver to the federal government, to CMS, and that was done on November the 20th of 2019. We had about a year of negotiations with the former administration at the federal level, and we received approval of this waiver on January 8th of 2021. And then we brought that back to the General Assembly, and the General Assembly approved that through a resolution on January 15th of 2021. Just as a reminder, so at its core, what we are attempting to do with TennCare 3 is really to fundamentally change what we believed was a flawed Medicaid financing model, where previously the only way that a state Medicaid program could receive more federal dollars was to spend more money. And we just think that that's kind of backwards. It's not the right way to do it. And instead, what we were looking to do is to be rewarded for our historical, effective, and efficient operation of our Medicaid program, and that reward would come in the form of additional federal dollars that we could then reinvest back into the program in an effort to improve health. And this is where the concept of shared savings comes in. Oftentimes, you'll hear this waiver referred to as the shared savings model or the shared savings waiver. One thing to point out is we did receive a 10-year waiver approval. That was very significant. Typically, these are 5 years, but we were able to negotiate a 10-year approval period. That's really important to us because it provided a level of certainty and clarity going forward for the next 10 years. You all have seen this diagram before, and it really illustrates what we were trying to change here. On the left side, what you see is we have a budget neutrality cap. And this isn't something that is unique to TennCare 3. It's actually not even unique to Tennessee. Any state that has an 1115 waiver for its Medicaid program has a budget neutrality cap. And this is not a set allotment of money that we get, but what it means is that if we go above that budget neutrality cap, we do not receive any federal match for the amount that we spend above that cap. We've never been close to that cap. We've always been below that cap. But historically, we haven't been rewarded for that, and all the reward has really been left in Washington at the federal level. So with TennCare 3, the way this works is if we're able to perform below our budget neutrality cap, we get to share in the savings, and that's where those additional federal dollars would come in, and then we could reinvest that back into the program. So we have been operating under this waiver now for almost 2 years, and despite some contrary statements by opponents of this waiver on the front end, there have been no reductions in benefits, no reductions in services, no reductions in individuals served. This really was and is about more, not less. It's really just the opposite. We've seen unprecedented improvements in our TennCare program. We are serving more people. Just this most recent year, in partnership with the General Assembly, we were able to add an adult dental benefit. That's where we're going to be able to serve 600,000 adults with a comprehensive dental benefit. That's the first time in TennCare history. We also are able, we've removed nearly 2,000 individuals that were awaiting services for our ECF Choices program. These are individuals with intellectual or developmental disabilities. It's been our goal to eliminate that waiting list, and we think that TennCare 3 provides a real opportunity for us to meet that goal. We've had a big focus in partnership with the General Assembly around maternal health, and we were able to extend postpartum coverage from 60 days to 12 months. That included a dental benefit as well. And then we've also increased rates to providers. We targeted specific areas. Of course, our MCOs negotiate rates with our providers, but we targeted specific areas where at the state level we determined we needed to make an investment. So we had increased dental rates for dental providers, behavioral health providers, and direct service professionals. And then also we were able to increase payments to our public hospitals through a revision to how we address certified public expenditures. So recently we have had some federal action on our waiver, and I wanted to give you all a timeline of events here. And so go back to 2021. In April, there was a lawsuit that was filed by a group of plaintiffs, and they actually sued CMS, and they were seeking to vacate CMS's approval of our waiver. In May, through the Attorney General's office, we intervened in that lawsuit. In August of 21, the plaintiffs agreed to stay the case pending a new public comment period that would take place at the federal level. So the public comment period took place. There was a lengthy review on the part of CMS, after which point, CMS communicated to TennCare that it had some concerns with our waiver, and they asked for revisions to address those concerns, and they wanted those revisions by August the 30th of 2022. So we went to work. We took a look at those concerns. We believe that we could still go forward with the major concepts of the waiver. So we published the intended revisions that we would make through an amendment. We published that. We had a 30-day public comment period. And then on August 30th, we did submit that amendment to CMS. Now CMS has published that amendment, and it's having its own public comment period. So a lot of steps here to get to where we want to be, but we are getting close to reaching, hopefully reaching some finality here. But again, I do want to point out that this doesn't stop the work. We received approval back in 2021, and we've been operating under the provisions of the waiver, and we have implemented the waiver. We're not waiting on this administration, this federal administration, to say go. We already got approval. Where we are now is that this administration is asking us to address some concerns that it has in an effort to be able to continue to move forward for that full 10-year period. So the next slide will give more detail on the kinds of things that we're talking about with the amendment. So the first issue, the first concern that the federal government had is they preferred that we had a per-member cap instead of an aggregate cap. The way that our waiver was negotiated, we had an aggregate cap, and which means that we didn't receive any additional or less funding on our cap space unless our enrollment changed by more than 1%. The way that per member cap works is we will get an adjustment regardless of whether that's one person or above or below 1%. That's something that we can live with. That's the traditional model. I think some would say that actually reduces the risk on the part of Tennessee because we're going to get an adjustment on our cap for 1 member, 5 members, 10 members, whatever the case may be. The reality is we already were at a per member cap because we've increased so significantly because of the public health emergency. So it's really not a big change for us. But either way, this is something that is agreeable to us, and we can move forward. The next piece, and one thing I really want to highlight, because I talked about before, the core principle of TennCare 3 is that we are able to be rewarded for our efficient operation of the program through shared savings, and that is not changing. We would still have the ability to draw down additional federal funds that we could reinvest back into the program. The 10-year approval period stays. The one significant change is the pharmacy flexibility. So we had negotiated the ability to have maximum flexibility in our pharmacy program. And if we chose to, we would have the ability to have a closed formulary where we could cover one drug per therapeutic class. We were the first Medicaid program in the country to receive approval for that flexibility. The current administration, current CMS, they don't really like that policy, and they asked us to remove that from the proposal. Now, the reality is we had not yet implemented that provision. We knew that that was something that this administration would likely have issues with. There's a legal debate about that. We believe that it's legal, of course, or we wouldn't have gone forward with it. The previous administration believed it's legal, or it would not have approved it. But we had not yet implemented that because we wanted to see how discussions with this administration would play out. So we're not losing anything in the sense that we have not yet implemented it, but we would lose the flexibility to have that closed formulary. So what that means then is that we have to cover any drug that is approved by the FDA, which is how it has been all along. I still would argue that it's the right policy for state Medicaid programs to have this authority. The Medicare program has this flexibility. Commercial insurers have this flexibility. So to me, it just makes sense that state Medicaid programs would have this flexibility. But when we looked at all of the concerns that were given to us by CMS, we determined that we could still meet the core provisions of our waiver and meet the goals and objectives and get that 10 years of certainty, and that would be beneficial for the state. So the next steps in this process, so the federal open comment period, public comment period, will complete in October. At that point, CMS will review the public comments. Then we will have additional discussions with CMS. We'll work out any outstanding issues that we have. Then hopefully we will have a final agreement and final approval. That will give us certainty for the next 8 years. And then the other important thing about that, if we can reach an agreement, then we will be able to pivot and draw down our year one shared savings. So the way that will work is we've already completed year one. That was 2021 calendar year. We believe we had a very successful year, so we believe that we are due shared savings. We have to work out the methodology around all of that, but we would be able to draw that down and then reinvest that back into the program to serve our members. And that'll be a really significant milestone in our efforts around TennCare 3. Mr. Chairman, that completes my comments on TennCare 3. I'm happy to answer any questions on that specific subject, or we can move on to the other waiver amendments.
Thank you, Mr. Smith. I will interject, and folks, Shelley's keeping a list, Ms. Adams is keeping a list. If you'd like to be on there, please get her attention, our attention. One of the last statements you made on slide number 8 there, discussing of potential shared savings. It may be premature to ask this question, but is there a ballpark, any ballpark idea from the first year's experience that we can or could expect from this?
Mr. Chairman, I'm hesitant to give a number because it really is all dependent upon the discussions and the interpretation of the language in the waiver. I can tell you that from our perspective, it should be significant, but I hate to give an estimate and then it's either way more than that or it's way less because. Depending on what the amount is, we could all think about programs that we might want to implement with those dollars.
Certainly, I understand completely. And with our chairman of the budget subcommittee in the room, he always perks up when we talk about dollars and cents as well. So that was a question asked on his behalf. That was the answer that I was expecting. But thank you for telling as much as you could on that. Any other questions at this juncture? Representative Lafferty, Chairman Lafferty, you are recognized.
Thank you, Mr. Chairman. The public comment period up there in D.C., I don't anticipate there's going to be too many Medicare, Medicaid patients up there doing that, asking questions. I recently saw a chart that showed a disturbingly high number of individuals that had moved from CMS to Big Pharma to some other medical profession to CMS. Lots of interloping there. Is that who we can anticipate is going to be making the public comments, is the pharmaceutical industry?
Well, I think that's probably an accurate assumption that the pharmaceutical industry will have public comments, but it's not unusual to have stakeholder groups that submit the public comments for this. I will say that we had to have our own public comment period, and we didn't receive nearly as many public comments for this public comment period as we did when we did the initial public comment period, which I think leads me to believe a couple of things. One, we've now been under this waiver for a couple of years, and the sky hasn't fallen, and we've made unprecedented investments, and we actually are serving more people in the program, and we've increased benefits and services. And then two, I think generally people feel pretty comfortable with the changes that we have proposed.
You recognize Chairman Lafferty.
Change pages back to the start of the conversation. The agreement that we had originally, why didn't we tell the federal government, hey, thank you, but we've already got this legal document in place?
That certainly was an option, and we actually still have that option. If they have the public comment period and they come back to us and they say, well, we can't give you this or we can't give you this, or they try to change the core fundamental principles of this waiver, then we still have the opportunity to say, well, we're not going to go forward. Then what will happen is we'll end up in a prolonged legal disagreement, and we want to try to avoid that if we can, because we really would like to get that certainty, and we really would like to get those shared savings from year one. If we can't reach an agreement and this goes, and we have to have a legal arguments, then who knows when we're going to be able to draw down those year one shared savings, and we're ready to get to work.
Okay. And
Chairman Lafferty.
thank you, Mr. Chairman. And just a comment. This is for my colleagues up here on the panel. This is for people out there watching that wonder why it is so difficult running a government, being entangled with a government. This is yet another situation where the federal government we've made an agreement with, then 4 years later, 8 years later, whatever it turns out to be, administrations change at the top, and then all of a sudden we find ourselves as a state scrambling to make up. And to my Democrat colleagues, it goes both ways. My point is, the less entangled we are with the federal government, the better off we would all be. That's my opinion. I'll leave it at that. Thank you, Mr. Chairman.
Thank you. Chairman Sapicki, you're recognized.
Thank you, Mr. Chairman, and thank you all for being here today. Just a couple questions, trying to explore a little bit more about what you've just talked about. You spoke about reinvestments with the shared savings back in the TennCare. Can you just give us a preliminary kind of high level of what you would see, what that would look like going back into TennCare?
Yeah, thank you, Representative. I'd actually point to things similar to the things that we've already done just here recently. The dental benefit for adults, eliminating the waiting list for individuals with intellectual and developmental disabilities that are awaiting services. Maternal health benefits, I think, are really important. So those are the things that we pointed to CMS. Those are the things that we've outlined in the waiver itself. It's hard to pinpoint exactly because we don't yet know how much shared savings we're going to get. Also, these are non-recurring dollars, and so we don't want to. We've been careful not to say these are the things that we are with certainty going to fund with the shared savings. We've given examples of the kinds of things that we want to do, but it would be those very types of things.
Chairman Sapicki.
Thank you, Mr. Chairman. And then in regards to the amendments that the Fed, that CMS asked you to do to our TennCare shared savings plan, are you experiencing any type of lack of flexibility in your day-to-day operations at TennCare that these amendments are putting on TennCare, or do you still have the flexibility that we had before these federal amendments or changes were put on TennCare?
Yeah. Thank you for the question. So right now we have the same flexibility that we negotiated because we are operating under the existing agreement. I don't anticipate those flexibilities would go away because we're not changing any of the language around the flexibilities, except for the pharmacy flexibility. That of course would go away. But everything else, we feel good about where we are. We feel really good about the amendment that we've submitted. We're very optimistic that we can reach an agreement. I think it's telling that this administration at the federal level didn't come in and then just immediately rescind this agreement. They did that in some other states, but I think they looked at what we were actually doing, serving more people, increasing benefits and services, and they actually realized that this could be a model for the rest of the country. And I truly believe that it can be a model for the rest of the country.
Continue, Chairman Sapicki.
Thank you, Mr. Chairman. And last one is the decision of Roe v. Wade is potentially going to lead in 9 months from now more children and more women showing up on our TennCare list, right? Are we going to have the flexibility and capability with our funding sources to make sure that with those increased numbers, because we all know that the success of a birth is due to the mother getting the prenatal care that she needs. Possibly drug intervention, right? Possibly substance abuse issues, right? And then making sure that that child, once that child is born, that we have the ability to make sure that that child receives all the medical care that it needs so that it can be successful. Are we starting to prepare for that in Tennessee so that we don't get 9 months from now, because 9 months puts us into June? Pretty sure we're not going to be here in June next year. So are you working on plans for the General Assembly that we may have to make substantive changes to TennCare to accommodate this increase in potentiality of having more women and children falling out of TennCare?
Yes, sir. Thanks for the question. So we're certainly having those discussions. We've already previously had an emphasis on maternal care, and I'm really glad that we had already started that previously. But we're having discussions right now about things that we can do moving forward to even enhance our efforts, and it's the very kinds of things that you're talking about.
Thank you, Mr. Chairman.
Thank you. Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. How much is your budget total?
It's about $13.9 billion.
And of that $13.9 billion, how much comes from the federal government?
Let's see, the federal government, it's about two-thirds. It's about two-thirds of that.
Well, to my colleagues, until we as a state can find another $10 billion, I think the federal government does have an obligation to have standards for these programs set up across the country. When we quit becoming a welfare state to the federal government, then we can talk about being on our own. But the federal government, thank goodness for Tennesseans, is sending about $10 billion a year to Tennessee for our Medicaid patients. Thanks.
Chairman Dr. Kumar, you're recognized.
Thank you, Mr. Chairman. Thank you. You touched upon the improvement in the DIDD list. Could you kindly just refresh our memory and give us the rough numbers?
Yes, absolutely. Glad to do that. It's something we're really excited about. We have a goal of eliminating that waiting list, and we were able to jumpstart that with some of the ARP dollars, specifically provided for home and community-based services. But then the General Assembly, in the most recent budget, agreed to have state funds invested to pick up that cost once the ARP dollars run out. And so what this is going to allow us to do is, at a minimum, we believe, reduce that list and serve an additional 2,000 individuals. We're going through the list now. What we're finding is that we actually have some individuals on the original list that either have moved out of state, no longer living in Tennessee, or they no longer are requesting services. So the list is actually less than what we had originally anticipated. And so what that means is we may be able to eliminate the list even earlier than we originally anticipated. So we're going through that process right now, and as we get to the end of the year and early into next year, we'll be able to come back to this committee with a report about exactly where we stand. But I think right now we've already served an additional 1,000. My last count was like 1,789. So we've made great progress.
Chairman Kumar.
Yeah, thank you. So how many people, I remember at one time the list was almost 5,500 or 6,000 people, and we've made some improvements. How many people are still on the waiting list?
Well, when we had budget discussions earlier this year, we projected about 4,000. So if we serve 2,000, that would leave 2,000. But as I said, we're actually finding that the list was less than 4,000, and we're trying to locate everybody that we possibly can right as we speak. So it's hard for me to put an exact figure on the number of individuals that would still be on the waiting list, but those that we've been able to find and identify, it's a very small number that would still be on the list. And we're trying to go through all that list and do everything that we can do to reach anyone that was on that original list.
Well, thank you. That's meaningful work. Thank you, Mr. Chairman.
Thank you. In closing out this section of the Q&A, Director Smith, if we could, back to the initial question I asked about the shared savings plan, and can you give me again the timeline, the time frames that we can expect to have shared savings determination with us? Do we have those dates in hand at the moment?
Well, what we do know is the federal public comment period will end on October the 6th. At that point, they will review the public comments, and then they will engage us in some further discussions. We don't know how long it will. Unfortunately, we operate under CMS's timeline. They don't operate under ours. So we don't know how long that they will take. There's been some indication that they would like to do this quickly. Sometimes CMS's definition of quickly is different from ours. But I would really hope that by the end of the year or very early next year, we would have some finality to this. Now, the other thing that throws a wrench into it is there's still this lawsuit that's hanging out there against CMS that we've intervened in. So I'm not sure exactly how all that will play out.
Okay. There may be more questions to come back to that in a few minutes. Seeing no more questions on this particular topic, Director Smith, let you continue with your presentation.
Okay, thank you, Mr. Chairman. Quickly, I'll go through. We have 3 other amendments that are pending before CMS. The first one relates to IDD integration, and so these are individuals with intellectual and developmental disabilities where we are integrating our home and community-based services for TennCare members into the managed care system. So these individuals already have their care integrated for physical and behavioral health. This would add the home and community-based service, wraparound service to that. This actually is tied to a budget item for the FY22 budget where we had recognized $34 million in additional revenue, and that is tied to the HMO tax that the MCOs pay. So we want to get this done for a number of reasons, both fiscal reasons, that $34 million, but also it's just a benefit to the program and to the people that we serve to have this single person-centered system of delivery of care. Amendment 2 relates to adoption coverage, and you all will recall this also was part of the FY22 budget where TennCare coverage would be extended to children who are adopted from state custody, and that would extend through the individual's 18th birthday. So fortunately, we have enough state dollars that were appropriated for this purpose to serve all of the children that are currently eligible, but we need to get this approved by the federal government because there's a compounding nature of this service because you have more children come in every year, and it extends to the 18th birthday. And I'll say both with all these amendments, we don't expect any issues. We believe that they will all be approved. The problem is they're just getting tied up with the other big amendment that I just talked about. CMS doesn't want to, they don't really want to move forward until they get the big amendment settled because these are amendments to that big amendment. And then the third one relates to enhanced benefits. These are enhanced benefits to members with disabilities. Enabling technology is the most notable benefit where we got approval to extend or to include that as a covered service. And then we got increased expenditure authority. Right now we're able to do this through an emergency waiver that we were able to receive because of the public health emergency. This would make that permanent. And again, we don't expect any issues on any of these 3. Happy to answer any questions on those.
I think we're good, Director. Forgive me. Representative Thompson. you're recognized on this topic.
Thank you, Mr. Chairman. Just a few questions on the amendments. One, the adoption coverage would cover all adopted children from state custody. Is that no matter what the economic circumstances of the adoptive parents are?
That's correct.
So a wealthy adopted family would still, the child would still be covered by TennCare, is that correct?
That is right. That is right. And
Okay.
I think it's designed as a way to really encourage adoption and to help families with that adoption process.
Okay, okay. I mean, I'm happy with a lot of the expansion that's done, a lot of the additional services. I've just always am skeptical when, we're talking about a lot more money. And, our budget's been very nice over the last few years. This last year we had seeming like more money than we knew what to do with. That's not. None of us expect that to be forever. We've had some pretty tight budgets in the past. What if that happens? Is that the potential for reducing or eliminating some of these benefits still there?
Well, we would have to go through a process if we were going to reduce or eliminate any benefits. I would say that if we find ourselves in that situation, then we're going to have just a bigger discussion that would involve the General Assembly and the budget process.
And it would involve CMS as well, I would assume.
It would. We would have to. We'd have to provide notice and go through the public notice process. But ultimately, CMS, they can't tell us. They can't force a state to indefinitely provide a benefit that's not required at the federal level.
Okay. Okay. Thank you.
Chairman Sapicki, you're recognized.
Thank you, Mr. Chairman. Kind of following up on that thought process. If a family adopts a child and they have insurance, private insurance, would TennCare be in a supportive role for that child, or would they be in a primary role for that child?
Mr. Chairman, if it's okay, I may defer to Aaron, our policy director, and he's probably the best person to speak to this.
Certainly. You're recognized, sir. Please, if you could, state your name and your position as you begin to answer.
Yes, sir. My name is Aaron Butler. I'm the Director of Policy for TennCare. And thank you for the question, sir. Yes, the policy goal here would be, of course, to remove potential barriers to adoption for children who are in state custody, for families with whom insurance may be a barrier or consideration, so that all children have an opportunity to be adopted into permanent homes. But in cases where a family has primary insurance other than TennCare, then you are correct. The commercial insurance or the private insurance would be the child's primary insurance. TennCare would be a secondary payer to pay for anything perhaps that the private insurance didn't cover, or things like that, in a secondary role.
Chairman Sapicki.
And a follow-up on that, hypothetically, if a child gets adopted from our foster care in Tennessee, and those parents move outside of Tennessee, is TennCare going to follow that child to make sure they're covered until possibly a new state insurance would pick up that child?
Thank you for the question. So yes, the overall policy goal here is to provide an incentive for adoption, to remove potential barriers for adoption. When we say cover all children adopted from state custody, there would be some exceptions. So for example, if a child passes away, if a child moves out of state, if a child enlists in the military and is no longer the responsibility of the adoptive parents, then TennCare coverage would end, things like that. So there are some exceptions like that.
Representative, we would no longer have the authority to cover that child if the child moved out of state.
Follow Chairman Sapicki.
I could be wrong here. I believe we did pass a law that Chairman Holt carried about covering children with disabilities outside the state of Tennessee if no program was able to be found for their remediation they need here. I believe we passed that already. If that's the case, my question would be is, now, I would understand that if a parent moved outside to Michigan, right, whatever, but what if a family adopted, I'm giving you a hypothetical here, what if a family adopted who's in the military, who serves in Clarksville and they live in Kentucky? Would we shut that child off from TennCare because they're serving in the military in Clarksville or in Hopkinsville, Kentucky? And I get what you're saying. I really appreciate, because that's kind of where I'm going with this whole, in 9 months from now, right? Making sure that these children are covered and adoption is as friendly as we can get it in Tennessee. Would we not have the ability to make sure that that child stays covered until there's a transitional plan from the other state? I'm sure most states have some type of TennCare, Missouri Care, Michigan Care, that child would be covered. So how would a child not, how do we protect a child not falling through the cracks?
It's a good question, and we can look into this state provision that you are referencing. I think the issue on the Medicaid side is that we are only authorized to cover Tennessee residents, and we wouldn't be able to draw down the federal match. Every state has a different match, and so I don't believe that we would have the authority to draw down a federal match for an individual that lives in Kentucky, for example. Now, if the state on its own wanted to have a provision that allowed for some continuity, then we could utilize 100% state funds to do that. But we will look into that state law that you referenced and see maybe if that has some applicability.
Thank you, Mr. Chairman.
Thank you. And Chairman Sapicki, we are researching that back here as we speak as well. I don't know if we'll have an answer by the time the meeting's done, but we'll certainly try. Director Smith, I want to lead you into the next part of our conversation that you've given to us in the PowerPoint. You had mentioned earlier we're just under a $14 billion program and substantial. And we have recently issued an RFP. All the ins and outs and all the programs that we've been discussing over the last 30, 45 minutes or so, have those been, are the potential providers within the MCOs, and not providers is the wrong word, the MCOs, I'll talk about that. Are the MCOs aware of all the ins and outs of what they need to include going forward and needed to include in their proposals to us? And I'll let you answer that as you begin the next segment of your presentation.
Thank you, Mr. Chairman. Yes, they are aware of where we are in the process. I think one of the real positive things about this TennCare 3 waiver is we really didn't have to change what we were doing from an operations perspective, from a day-to-day perspective. All we had to do to be successful was just keep doing what we were doing and have an efficient and effective Medicaid program, spend below that budget neutrality cap, which we have always done, and then we get the benefit of those shared savings dollars. More specifically to the MCO work, one of the things that we were asked to do is to give an update on contracts. And, of course, TennCare has many, many contracts, but the contracts that get the most attention are the MCO contracts, and rightly so, because these are the largest contracts that we have in state government. And so there's a lot of interest in those contracts. And I thought maybe to level set, it might be beneficial to go through a timeline of events relative to the most recent MCO procurement. And so that's what you see on the screen there. So go back to 2021. In June of 2021, we issued the request for proposals for the MCO contracts. The evaluations of those contracts were completed, and there was a notice of intent to award in November of that same year, 2021. There was a protest that was filed by a losing bidder. That was done on November 15th of 21. There's a process in law that outlines what a protester needs to do to protest an award. And so the first step is that protest goes to the Central Procurement Office. And so that protest was filed. The protest was denied by CPO in January. Then the protester appealed that denial to the State Protest Committee. That appeal was in January. The State Protest Committee in July of 2022 unanimously upheld the CPO denial and ruled in favor of TennCare. Most recently, the protester filed a petition for judicial review in Davidson County Chancery Court, and that happened very recently on September the 12th. Not really coupled with this, but I do want to clarify, we currently have 3 contracts before the Fiscal Review Committee. Actually, it's up before the Fiscal Review Committee this week. These are amendments to the existing MCO contracts, very separate from the new contracts that we're talking about with this procurement. So we have existing contracts with 3 MCOs. We routinely bring amendments about every 6 months to the Fiscal Review Committee for technical changes. And so the amendments that are before fiscal review, those are the typical technical changes. We are not seeking an extension in the amendments that are before the Fiscal Review Committee this week. So I do want to make that clarification. Now, we have 2 paths forward. We either have to move forward with the new contracts that were awarded per the procurement, or we're going to have to eventually extend the existing contracts because the existing contracts expire at the end of this year. So we either have to move forward with the new contracts or we're going to have to extend the existing contracts. Otherwise, we won't be able to operate a Medicaid program because we won't have the authority to pay claims and to have a provider network and all of those things that are necessary because we are a managed care state. And so it's very important that we do one. We're going to have to do one or the other to be able to move forward. So I did want to clarify that. So with that, Mr. Chairman, I'm happy to answer any questions with the caveat that this is now under active litigation, and so I may be limited as to what I can say.
Thank you, Director. You've told us that we are looking at the end of the year to continue the existing contracts with our 3 MCOs. Is that accurate? The what-if scenario, if the protest is still ongoing and still being litigated, what does that do? Are we operating under we've talked about the federal government several times in here lately, they like to operate on continuing resolutions. Are we operating under some type of quasi-continuing resolution at that point in time?
No, Mr. Chairman, there's not an automatic continuing operation. That's why we will either have to move forward with the new contracts and execute those contracts, or we will have to come before fiscal review before the end of the year and get that extension. It's going to have to be one or the other.
Thank you. Chairman Sapicki, are you ready to ask a question or two? Okay, Chairman Sapicki, you're recognized.
Thank you, Mr. Chairman. So, kind of broad, I'm going to broaden out on this MCO issue here. You know, I've been looking at this, serving on the TennCare committee for 4 years. I know some of you have served a lot longer than I have. One of my greatest concerns is the lack of competition with the MCOs in general. There are, and I know statutorily it's capped at 3, I believe. Is that true?
It's not in statute, Representative, that this is a internal policy that we have chosen, and there are multiple reasons for that. I'm happy to go through those, but it's not in state statute that we can only have 3.
A little flexibility, Mr. Chairman.
You're recognized, Chairman,
Thank you.
to go back and forth.
Thank you, Mr. Chairman. So, so TennCare does have the ability to expand it to 4, to expand it to 5, to expand it to 15 if they want to, or to expand it to any MCO that wants to come in, as long as they meet the qualifications put forth that you have as an organization, that they could come in and be an MCO for Tennessee and provide health care to people in Tennessee. One of the things that I believe in is competition in the marketplace. We have 3 MCOs right now that have cornered the market in Tennessee. I can give you the data. You already know the data. There's 3 of them. And one of the things I think that we could do to help our shared savings plan and to help the people of TennCare who are on TennCare and to be able to expand services is to bring competition into those 3 MCOs to help provide the best care for the people of Tennessee. That's the bottom line of what we're here for, right? To provide the best care for the people of Tennessee that unfortunately are in a situation that they need TennCare. You know, we tried to do this last year with a bill to expand it. And I think we really need to continue to look at that is, are we doing what's best for the people of Tennessee, where we could bring competition of other MCOs, and the list is endless here. New Jersey has 5, Washington has 5, Virginia 5, Louisiana 5, Indiana 5, Maryland 9, Kentucky 6, Wisconsin 14, Minnesota 8, Oregon 12, South Carolina 4. It's all over the place. And I don't think we should set a scale to say, you know what, we're going to be 3 and 3 only. Why wouldn't we let the marketplace determine that? Why wouldn't we let the MCOs determine that, with the auspice of making sure that TennCare makes sure that these MCOs meet the requirements put forth to provide health care to our individuals in Tennessee. So that's one thing I hope that you can consider, and as legislators, I hope that we can consider is, you know, give TennCare the opportunity to expand and bring competition into the marketplace to provide better coverage. And if that's not going to happen, then I think we need to really consider ourselves as legislators here of making sure that we're doing what's best for the people of Tennessee on TennCare, and to provide the best service, the most cost-effective way to do it. I think the way you do that is to bring competition in the marketplace. You want to comment?
Yeah, thank you for the comments. And I believe that the right conversation around this subject is, I think there is a policy debate to be had around the number of MCOs that we choose to go forward with, rather than why did a losing bidder not score higher than the third place bidder. And maybe it'd be helpful to discuss with the committee about why we chose 3. And for us, and for me, it was really about looking at our own history in the TennCare program. And we've had experience with 3 for a number of years, and we've had experience with more than 3. Tennessee really is the leader in managed care nationwide. Today, states have followed TennCare's lead and Tennessee's lead, where you have 70% of individuals in Medicaid across the country that are served through a managed care organization. So we've made, as a TennCare program, you all have seen the charts, we've made all the mistakes that you can make in Medicaid, and we've learned from those mistakes. And when we look at the greatest period of success for the TennCare program, it's the period in which we had 3 MCOs. And I'll give you some examples. And it's not to suggest that it's only the number of MCOs that lead to the success, but we do think that's an important piece of it. So from 1997 to 2008, we averaged 8 MCOs in this state. And our annual increased spend was about 6.5%. Clearly, that was unsustainable. From 2009 to 2020, where we had 3 MCOs, we've averaged an increased spend of 2.4%. And this makes logical sense. More lives covered by an MCO results in a better deal for the state, because it reduces the risk on the part of the MCO. So we get better capitation rates. We pay less in administrative costs. We need less staff at the TennCare level to monitor. And frankly, we get more attention from the corporate offices with the more lives that are being covered by a particular MCO. From a quality standpoint, because I know that TennCare often gets criticized for only caring about money, and I dispute that. I think in order to be, our mission is you have to have cost effectiveness, and we also have to have quality in order to improve lives. And I really believe you have to have both to be successful. You have to be successful in both. But being cost effective actually allows us to improve quality because we can serve more people. and we can improve the services that we provide. But for the most recent year with completed data, TennCare Tennessee is performing better than the national Medicaid average in nearly 60% of the individual HEDIS measures. So these are measures that all the states have to provide to CMS and report on. Compare that to 2007, we beat the national average in only 40% of those measures. So we've seen clear improvement over time. From an access standpoint, we believe that our provider network is stronger today than it has ever been. We have a survey that's done every year, not by TennCare, but by the University of Tennessee, where they gauge customer satisfaction. So these are actual Medicaid members that are rating our work. The most recent results, we have a 92% customer satisfaction rate. That's the 13th consecutive year where we've been above 90%. From a provider perspective, there's less burden and bureaucracy for the providers with the fewer MCOs that you have, less negotiating and renegotiating contracts, less credentialing, less communication around payment issues, prior authorization, all of those things. Now, is it accurate that some providers may get a higher rate with another MCO that comes in? It's probably accurate, but it's also just as accurate that some providers would get a lower rate. So it is, to your point, Representative, I do think that there probably is a debate around innovation and competition with additional MCOs, but I think the question is, does that potential benefit outweigh the certain risks? And one of the certain risks is additional cost on the part of the state. With the bill that was introduced earlier this year that would have required a fourth MCO, there was a $90 million cost to that. Now, that's not all state. That's about $30 million state. But we don't believe, from a TennCare standpoint, we don't believe that the potential benefits would outweigh all of the potential negatives and the certain negative of the additional cost to have an additional MCO. So I hope that helps somewhat, but I wouldn't argue with you that I wouldn't say that it's not a worthy policy debate.
Chairman Zapicki, I'm going to interject here before you go on, if I could. Anecdotally, Director Smith, I have heard from numerous professionals across the state that you mentioned there is negotiation between provider and MCOs. Several of the provider communities would think there's not real negotiation. It's almost, this is what the MCO is going to pay and this is what the provider is going to take. And we have had those discussions over the last couple of years. I don't know if you want to comment on that, but that's part of the reason we're having some of these policy discussions, part of the reason we had some of those policy discussions over the last calendar year and why we're still having some discussions now.
Yeah. Thank you for that comment. So typically when we hear complaints from providers about an MCO, it usually is around rates. We've talked about this in this committee before, where there is a healthy tension between payers and providers. Certainly, when you're talking about a taxpayer-funded payer, and I do think that tension is healthy. What we focus on at the TennCare level is we have to ensure that we have an adequate network of providers, so that our members can be served when they need services. I would take the position, I do take the position that adding another MCO or two more MCOs or three more MCOs, it's not going to alleviate, and it certainly shouldn't alleviate that healthy tension. But as I mentioned before, if you have a fourth MCO come in, some providers may get a higher rate, but some providers will also get a lower rate. That's just kind of how managed care works. And we hold the MCOs at risk. And so part of holding them at risk is they negotiate the rates with the providers. And we're very careful not to not to inject ourselves into that, because ultimately it is the MCO that's at risk. Now, we hold the MCO accountable for having an adequate network of providers. And we certainly listen to our providers when they do have issues with the MCO. We try to first have them go to the MCOs directly and have those conversations. But there are times where, we will facilitate conversations.
Thank you, Director. And I will note on slide number 5 on your presentation earlier, we did have increased rates because through dental, behavioral health, direct service professionals, increased payments to public hospitals. Those are hopefully reactions to the legislative branch saying there's some issues here, there's some problems here. It was quite time consuming and took a lot of effort to be heard on those issues, and hopefully in the future it won't take quite as much effort that we're going to be heard the first time around. Chairman Sapicki, did you have some follow-ups, please?
I did.
Chairman Sapicki, you recognized.
Thank you, Mr. Chairman. Let me shift gears again on you here a little bit. So I don't think you were here in 2016 as this position. Is that correct?
Correct.
Okay. So in a final rule by CMS in 2016, they stated that the states needed to be at an 85% HBR, health benefit ratio. We are not there still. And I've gone back and looked at all the data since 2014, and only one provider in 1 year has been at an 85% health benefit ratio or greater. Only one. Currently, the 3 MCOs one sits at 76.9, one sits at 80.5, and the other one sits at 80.8. Below what CMS has stated that they wanted us to do back in 2016. Now, I know we don't have anything statutorily requiring a health benefit ratio going out so we can pay better for our providers, to provide better payments to our hospitals that border on rural communities. The hospital that I represent, Murray Regional, provides basically all of the health care to all of southern Middle Tennessee below Murray County and pretty much east and west. One of the complaints we get is our rural health care is lacking so much in Tennessee. Having conversations with my hospital, it's because of the lack of payments. We get back to the argument that the chairman made, is these negotiations, which one could argue is when one's holding all the money and all the cards, what kind of negotiations are you truly having? And you have to play by that. We saw this argument last year when I ran the bill on pharmacy benefit managers. The argument of these providers dictating what they're going to be paid. And so do you care to comment on that, of why haven't we met what the CMS has asked us to back in 2016 of being at least an 85% health benefit ratio?
Thank you for the question. I'm not familiar with HBR. I guess we're more familiar with the medical loss ratio.
Interchangeable terms.
Okay. Well, then I think it's important. I think our data would be different from your data. And Zane, I don't know if you're prepared to talk about that, but
yeah,
Sir,
absolutely.
if you could please introduce yourself, your position, and continue with your answer.
So my name is Zane Sills, and I serve as the Chief Financial Officer for the Division of TennCare. Thank you very much for your question. So in 2016, and we may be talking about slightly different topics here, but in 2016, CMS did release what was called the Managed Care Final Rule, and that was a over 1,000-page regulation. It did a lot of things, but one of the requirements that it put in place was that when managed care states like Tennessee set capitation rates, we are required to set those capitation rates with the intent that the MCO would achieve no lower than an 85% medical loss ratio. So the requirement in that regulation is not that the MCO actually achieves a certain medical loss ratio at the end of the year, but prospectively on the front end that the state's actuaries, when they're setting actuarially sound capitation rates, have to set that with the goal that the capitation rate would be no lower than 85%. So we have been compliant with that rule ever since it's gone into effect. In fact, our actuaries were already setting our cap rates that way even before 2016, before CMS put that rule into effect. And for the past several years, our MCOs are consistently statewide, having MCOs above 85%. There may be one point of confusion on how that calculation works, where the state here in Tennessee has a 6% premium tax. And so that does not count against the MCOs. And so you may, if you count it, you may have an MLR of 82, but if you don't count it, it's an MLR of 88. So CMS's requirement applies to the net of premium tax calculation, and so that's how we do it. And our MCOs, according to that methodology, are consistently above 85%.
Chairman Sapicki?
So you're saying they're achieving that with the tax on it?
Once you net out that state premium tax, we are, yes, sir, compliant with the intention there and federal rules.
And can you describe the tax and what its purpose is?
So in state law, we have a 6% premium tax on health maintenance organizations. And so that has been in place for many, many years, certainly predating my time at TennCare 11 years ago. But basically, the state imposes a 6% tax on all health maintenance organizations in the state, and they pay 6% of their premiums to the state as a tax that goes into the state general fund.
To the general fund?
Yes, sir.
Is okay.
Continue, Chairman
So-
Sapicki.
If we're talking about TennCare dollars, right? That's what we're talking about, right?
Well, those tax dollars from the premium tax go into the state general fund.
Okay, but the MCO is paying that tax from TennCare and CMS funds, is that correct?
Yes, sir. So they pay those taxes out of the capitation rates that we pay them, which is a mixture of state match and federal matching dollars.
So they're paying a tax from their corporation with money that's provided to them by Tennessee taxpayers and federal taxes?
Yes, sir. Ultimately, all dollars that are paid to them in capitation rates are taxpayer dollars.
All right, thank you.
Thank you. Going back a few statements ago, and as you were having this conversation with Chairman Sapicki, we were talking about approved rate increases for some providers. How is this being accomplished through some type of tax? How are these? Let's talk about how these increases to providers are being accomplished, if you could.
Thank you, Mr. Chairman. So these are accomplished through what's called a directed payment, and if it's probably best to have Zane kind of walk you through how that works, but it's different from the typical. It's not the MCO rate negotiating. It's a directed payment where we are essentially saying, as a state, we're gonna pay these additional dollars.
Cecile, you recognized.
So I think you may be asking about certain of the investments that we made in the last budget cycle, and when we talked about those earlier, investments for dental, investments for behavioral health, and home and community-based services. So those all went through the budget process. So ultimately, those dollars were approved and allocated by the General Assembly. So again, general fund dollars. I think it's important to note that on some of those funds, particularly the HCBS funds, as part of the ARP, Federal Congress passed a temporary bump in the state's match rate for certain types of services. And so we were able to use those funds for a period of 3 years. We're still in the middle of that right now. And so when we went through the budget process, we said, we want to make these increases. We can use the additional federal money to pay for them for a period of 3 years. And then the legislature approved that, but also approved that when that 3-year period expires, to use state general fund dollars as the state matching portion.
Thank you. That's very helpful. I appreciate you bringing that home for me. Thank you very much. Committee members, questions or comments? Chairman Dr. Kumar, you're recognized.
Thank you, Mr. Chairman. If you will indulge me, I'm going to step out of the declared agenda of this proceeding and question about TennCare that I get in my district at times has been people who were removed from the rolls and reinstated. and where do we stand, and how many people, as some of the federal funds expire, are in danger of being left off. Kindly give us a landscape so I can answer people in the district.
Thank you for that question, Chairman. So what you're referring to is that during the public health emergency, we have been prohibited from removing anyone from the rolls, and so we have paused our redetermination process, and that, of course, has led to a significant increase in our enrollment. We are up about 20% since March of 2020. So that's about 285,000 individuals who are, that's an increase over where we were. It's hard to know specifically how many of those individuals will eventually come off of the program, because they will go through that redetermination process where they will have to provide the necessary documentation to ensure eligibility. So we'll go through that process. We've been asked to make our best projection. Our best projection is we believe that after we go through the 12 months and everyone goes through redetermination, we believe that we will be back around 1.4 million. Right now, we're close to 1.7 million. Now, that is our best projection. We don't. That's not certain. We will have to go through that process and see ultimately who is eligible and who is not.
Thank you. So what will be the reason that these 300,000 or so people will be off the TennCare enrollment?
The most common reason would be a change in income status. Okay. That would be the most common reason.
And there is an appeals process?
Yes.
Thank you. Thank you, Mr.
And if I can, Mr. Chairman, I'll put in a plug, because we are doing everything that we can right now while the emergency is still in place to communicate with our members that it is vitally important that they update their contact information with TennCare, because we have to have a way to get information to them. By law, federal law and state law, we cannot keep someone on the Medicaid program if they do not provide the necessary documentation that they are, in fact, eligible. So we really need everyone to respond to TennCare mail and TennCare communication when we provide that communication. And we're doing that in many different ways now. It's not just traditional mail, email, text messaging. We have our new eligibility system that has been modernized, and it's now in place. And so the process is going to be much easier than it has been in the past. But ultimately, it is the responsibility on the individual receiving the benefit to provide the information that we must have to continue enrollment in TennCare.
Thank you.
Thank you. As Chairman Dr. Kumar has taken us down the path of some issues that may or may not be on the agenda, I have a couple of questions too, Director, if you could. The issue of the day, issue of the last week, really in the state of Tennessee, for TennCare, are we, I'm sorry, for TennCare, do we cover and or pay for transgender reassignment surgeries for minors?
We do not, Mr. Chairman. We have a specific exclusion in our program for that service.
Okay. And if you could continue in that vein, does TennCare cover and or pay for hormone blockers for minors in certain situations? If you could please answer that. And if you have a ballpark idea of any type of costs that might be associated with that, that would be helpful as well, Director.
So the blockers that you just mentioned, so we do not have a specific exclusion for that, which means that it would be covered if it meets medical necessity guidelines. It would be very rare, and I know that this body passed legislation a couple of years ago that would prohibit a provider from providing those services. So in many cases, so we would never get a claim that would be we should never get a claim that would be in violation of that legislation that you all passed. But there is no specific exclusion for that particular service. And so it's possible that it could be covered if it went through that whole process and it was determined to be medically necessary.
Two words we've heard a lot the last couple of years, medical necessity. So,
Yes.
Chairman Sapicki, did you have a follow-up?
I did, Mr. Chairman.
You recognized?
So kind of going back over here, I just want to clarify something here. The 6% you're talking about, does CMS recognize that in their medical loss ratio? Because the 6% has nothing to do with the health care provided to the citizens of Tennessee. That's a tax that we put on the MCO. So does CMS recognize the 6%, or do we recognize the 6%?
CMS, they do not count that as part of their calculation, the methodology they use to make that requirement. So we're consistent with CMS and not counting it.
So you're telling me, I thought you just told me that we do count the 6%, which allows them to get over the 85%.
No, that's excluded from the calculation for purposes of measuring MLR. MLR is calculated net of premium tax, both by how the state looks at it and also per CMS.
So what you're telling me, I want to get this straight, is that the numbers that I have are provided by CMS, and the numbers I'm giving to you are from CMS, but you're telling me our MCOs have higher numbers, but you made a statement that if you take the numbers plus the tax, it gets them over 85%. Is that what you're saying?
I haven't seen those numbers from CMS. My apologies. It would be very difficult for me to say exactly what you're looking at. But if we were able to take a look at those numbers, we could maybe explain what's going on there.
Let me ask a better question here. The numbers that you have that you can probably pull up for our MCOs of their medical loss ratio, that percentage, that 86%, that 87%, does that include that 6% tax counting for them, or is it excluded from those numbers?
Excluded.
So you're telling me that they are all above 85% right now in the state of Tennessee on their medical loss ratio?
Oh, well, the calendar year 22 numbers are not yet final.
Last year.
So last year, those numbers are also not finalized yet because we have a risk corridor in place for calendar year 21. So we're currently finalizing those numbers as we speak.
So how about in 20?
In 20, I'd have to go back and check. I believe they were above 85, but I'd have to go back and check.
So if you could provide the chairman that information so he can disseminate it to this committee, so we know that from the last data we have, our MCOs are meeting our 85% threshold for medical loss ratio.
We'd be happy to share that data with you.
Thank you, Mr. Chairman.
Thank you. How quickly can we get that information?
Day or so.
Okay. As we wrap up here, looking to my committee members, Director Smith, can you talk to us? Let's go back to the MCO issue again, and what we're looking at. Absent nothing happening, we're up against a deadline of the end of this year, and potentially going forward. What time frame are we looking to go forward with the existing 3 MCOs, absent the protest and a protest success? What time frame will these contracts envelop? How far are we looking out in history?
Well, we're looking at the very near future, so it would be January 1 of 23. Now, I can't speak for any action that the plaintiffs in this case would take. Currently, there is not an injunction, but we're going to have to do something by the end of the year. As I said before, we're either going to have to execute these contracts, and we would start with these new ones, January 1, 2023, or we will have to have an extension of the existing contracts and continue with those existing contracts.
The legality of the extensions, is that something that the state's attorney general is looking into? Is that something that we can do, extend those? Is that something we cannot do, and give me a time frame on that.
We do have the authority to extend those contracts. It's ultimately a decision for the Fiscal Review Committee. But we do have that authority, and in fact, we extended it. We actually extended it a year previously because of the public health emergency. So we already had one extension year after the option years, and so we do have the authority to extend.
Director Smith, when would the next RFP occur after this January 1, 23 timeframe we're looking at? When is the next timeframe?
The next one, Drew maybe can correct me if I'm wrong, but the new contract, it's a 3-year contract, and then there are 5 option years where we have the ability to exercise the option. So at its most, it would be 8 years, but then we would, of course, have to put out the RFP well before the expiration of that. And I'm trying to think about the timeline, but it's a 3-year contract with 5 option years.
In order to exercise those options, is that something that has to go through fiscal review? Does that go through a legislative process?
It does. It goes to fiscal review.
Each year, or okay,
Each option year.
I'm seeing heads nod that it would be yes. Okay, thank you. Chairman Speaker, you recognize.
Thank you. So these contracts, if the General Assembly wanted to move to expand MCO's next legislative session, if these contracts are signed, would that prohibit the General Assembly from expanding the MCOs?
I don't believe it would. I think we would just have to procure another. We'd have to go through another procurement to add one more MCO.
Or whatever the General Assembly wanted to do.
That's right.
Do we have to do anything right now, or can we wait until the General Assembly comes back? Because this bill was up before last year, so this is a conversation that probably the whole committee would need to have on whether or not we want to move forward. Could we postpone the contracts until we get to January, and we could come back into session?
Well, we have to do one of the following. Either we have to execute these contracts, the new contract, or we have to extend the existing contracts. Otherwise, we have no contract in place and we can't operate the program. So one of those things has to happen.
So could you not just extend, because we got 3 MCOs, right?
We did.
And the contracts are for those 3 MCOs, is that correct?
Yes.
And those 3 MCOs are going to abide by all the rules and laws that they have to abide by, correct?
Yes.
So could you not just extend their contracts until the General Assembly comes back in? And if the General Assembly chooses not to expand the MCOs, then you could put the RFP out for the contracts and you're done, or leave the extended contracts in place. If the General Assembly doesn't act on anything, then why wouldn't you just extend them until we come back into session and start to make a decision on working with you, what's best for the people of Tennessee? Could you extend them?
We can. Again, ultimately, it's a decision for the Fiscal Review Committee, but we do have the option. The state has the option to extend the existing contracts. That's correct.
Mr. Chairman, do we have the ability to make a recommendation to Fiscal Review?
I believe we do. If there were to be a motion made by the committee, we have continued to exercise a quorum as we have been meeting, so we do have a quorum.
Can we take a 2-minute recess?
Has been whispered in both of my ears. It is to take a recess. We
Take a
will not.
recess.
We will not put a time frame. We will take a very brief recess and gather around the chairman's desk, or chairman's chair right here. right, we are back in session. Thank you. And we are up against a hard stop here. Chairman Sapicki, you are recognized.
Thank you, Mr. Chairman. To maintain the greatest flexibility we have in the General Assembly and to not get us off on the wrong foot here, Mr. Chairman, I would like to make a motion that this committee takes a vote, and what the vote would be is to urge Fiscal Review Committee to deeply consider extending the contracts instead of issuing new contracts, to buy the General Assembly time until we come back into session in January and can discuss this issue further. So in the form of a motion, that's what I'm making, Mr. Chairman. Is that worded correctly?
We have a motion. Do we have a second? As we were discussing this, it's been requested to take another brief recess. We are in recess. House Insurance Subcommittee is back in session. We are out of recess. Chairman Sapicki, I'll recognize you.
Mr. Chairman, I'd like to withdraw my motion.
Okay. Motion has been withdrawn. I can't recall if we ever recognized a second or not, but motion has been withdrawn. Chairman Sapicki, you are recognized.
Thank you, Mr. Chairman. Mr. Chairman, if it'd be possible, if yourself, Chairman Hawk, and Chairman Kumar could just send a letter to the Fiscal Review Committee asking them to consider extending these contracts instead of issuing new ones to give the General Assembly more time to consider whether or not we're going to expand the MCOs. That's all. Thank you, Mr. Chairman.
Duly noted. Thank you. Director Smith, as we're closing up here, would you like to make some comments?
Thank you, Mr. Chairman. Just one point of clarification that may be helpful to the committee. For the Fiscal Review Committee does not issue new contracts. They are responsible for extending, so I just wanted to make that clarification. That was.
Thank you. Director Smith, any more comments in closing? Anything you'd like to close us with, and then we'll go to committee members as we are up against the clock here.
No, Mr. Chairman, committee members, I'll just say thank you for the discussion and appreciate the opportunity to be with you all this afternoon.
Thank you. Thank you, Director Smith, your team. We really appreciate that. Any comments or questions from committee members? Seeing none, we are adjourned.